I think in 2021, 537 million people between the age of 20 to 64 years, and this is going to be 783 million by 2045. That is, 3 in 4 adults with diabetes live in low and middle income countries. Diabetes in India, you all know we are the second capital next to China, and still I think our population has exceeded China, and in diabetes also we are going to exceed China. See, we all know the site of action of pharmacological therapies for treatment of type 2 diabetes. And today we are going to talk on glitazones, and you can see it acts on the liver, the adipose tissue, and the muscles. And you know the important action here. And first of all, positioning of pioglitazone. Patients in whom the benefits are likely to exceed the risk. This is how we can position pioglitazone at this time. As a one oral agent where metformin is contraindicated and can't be used, then insulin-resistant patients with renal impairment and cost is a concern, then this can be used as a single drug. In 2 oral drugs on top of metformin, again in insulin-resistant patients, that is, the following markers of insulin resistance will predict a good and sustained HbA1c reduction of pioglitazone, that is with abdominal obesity, slightly increased liver enzymes, low HDL levels. This will be the type of patients with insulin resistance. And at high CV risk, you can see post-MI if no heart failure, post-stroke, chronic kidney disease, diabetic dyslipidemia, and NAFLD has been changed to metabolic associated liver diseases. Recently the name has been renamed, and because it is a secondary prevention. Mostly this has a very good benefit in the secondary prevention. That's what we are going to see in the next few slides. And as a third oral agent, triple oral therapy, where you have to stop insulin because of hypoglycemia and other things. I think only with tablets you want to manage, then again this can be added. And with the injection on top of insulin, when large dose of insulin fail due to insulin resistance, and when your sulfonylurea and metformin is also not giving that much of effectiveness, there also this can be placed. And pioglitazone is a potent insulin sensitizer. You know, the core pathophysiological defect in type 2 diabetes is insulin resistance. We all know very well. In muscle and liver and beta cell failure. Insulin resistance liver results in excess glucose production during the sleeping hours, leads to fasting hyperglycemia. That is because of the hepatic glucose output, because of insulin resistance in the liver. And insulin resistance in muscle leads to postprandial hyperglycemia. Progressive beta cell failure leads to insulin resistance in liver and muscle. And it has a protective action on multiple organs. You can see in stroke, there is a reduction of 47% of secondary stroke in patients with previous stroke. That is the proactive trial. And again, that same trial showed a 28% reduction in the reinfarction in patients with previous MI, secondary prevention. And again, a 37% of acute coronary syndrome after previous MI, that is again a proactive. And again, Chicago trial showed us the reduction of carotid intermediate thickness, which was shown by Chicago trial. And the periscope again showed a stop of progression of coronary atherosclerosis. And again, proactive showed a decrease in the MI, stroke, and death in patients with CKD. That is again found in the proactive. And the quarter trial showed the reduction of microalbuminuria. And in the liver, reduced reduction of inflammation and necrosis in NASH. That is MASH. Now it has been recoined. Nearly 50% of risk reduction for hepatocellular carcinoma. We have been talking about urinary bladder cancer, but it has a protective action on hepatocellular carcinoma also, again a liver cancer. And some major trials have shown proactive, 2005, 16% reduction in the composite risk of all-cause mortality, non-fatal MI, and stroke in type 2 diabetic patients at high risk of macrovascular events. The sound and a meta-analysis of nearly 12,000 patients with 9 randomized controlled trials in 2017 showed cardiovascular events, MACE, composite of non-fatal MI, all reduction was seen. Again, in the same meta-analysis showed non-fatal stroke and cardiovascular death are reduced by 23% pre-diabetic and insulin-resistant subjects and 70% in diabetic patients. So meta-analysis of nearly 10,000 patients of 10 RCTs showed a reduce in the recurrence of MACE by 26%. And meta-analysis of nearly 19,000 odd patients of 26 randomized controlled trials showed a 20% reduction in the risk of MACE. So the benefit of pioglitazone was consistently greater in secondary than primary prevention. Showed a very good benefit in the secondary prevention rather than in the primary prevention. And there is an important connection here. You can see that recently this is emerging very well. Before diabetes and heart failure, which was not seen a decade since the heart failure is being taken to the diabetic, and we have so many other Rambam to tackle that. And now this entity is very, very important. You can see both the conditions, type 2 diabetes and MAFLD, share underlying pathophysiological mechanisms that exacerbate each other, promote worse disease and comorbid condition. That is, in type 2 diabetes, you can see diabetes, increased risk of steatohepatitis, increased risk of cirrhosis and hepatocellular carcinoma when the person is having diabetes. Again, the same person, if he is having metabolic associated liver disease, promotes worse insulin resistance and increased risk of atherogenic dyslipidemia, increased risk of type 2 diabetes, and increased difficulty to manage, and increased risk of cardiovascular disease also. So now this entity has become a very important entity. So these things, type 2 diabetes and NASH are both consequences of insulin resistance, and NASH is largely unrecognized. Like heart failure a decade ago, this has been unrecognized complication of insulin resistance. Now it is gaining more momentum in the recent years. And you can see the global prevalence of MAFLD among type 2 diabetic really 55.5%, more than 50%, same like heart failure. And there is a risk stratification. I don't want to go into this thing to stratify the type of low or moderate or high intensity liver diseases. And here you can see modalities to control diabetes and NAFLD. Low risk with FIB score and the liver stiffness thing and elasticity, everything has been calculated. According to this, the fibrosis risk is stratified, low risk, intermediate risk, high risk. And you can see in the dietary recommendation, glycemic load reduction via emphasis on whole food carbohydrates. Nearly 30% carbohydrates has to be given here versus sugar and processed carbohydrates. And individualized A1C. More than 6.5 for persons without concurrent serious illnesses and at low hypoglycemic risk, more than 6.5 for these people. So less than 6.5 in other patients. And in advanced cirrhosis, caution with risk of hypoglycemia and avoid oral agents. In cirrhosis, no drug has been approved. It is contraindicated. So accordingly, you can see preferred diabetic therapy in the low risk group, again considering that because it has a very good reduction in the liver fat, and pioglitazone and GLP-1 has been approved. Strongly consider that reduces NASH. In NASH also pioglitazone thing. Strongly consider that reduces NASH, pioglitazone and GLP-1 receptor agonists. And again in cirrhosis, avoid oral hypoglycemic agents. Again you can see oral anti-diabetic continue glycemic benefits, limited benefits on NASH, SGLT2, DP4. All these things have a benefit in the reduction of liver fat and NASH. And you can see pioglitazone in the NAFLD, reduce insulin resistance, reduces fibrosis, which is a very important factor, and it reduces the lipid concentration also and reduces inflammation. So the vast majority of meta-analysis have proven that pioglitazone is both safe and effective in treating patients with MASH, even in those with significant fibrosis. It's a very important take-home message. And you can see this one more trial, long-term pioglitazone treatment is effective and safe for patients with NASH and pre-diabetes or type 2 diabetes. 101 patients with pre-diabetes or type 2 diabetes, and biopsy-proven NASH have been recruited, and all patients were prescribed a hypocaloric diet and from deficit from weight maintaining caloric intake, nearly 500 kilocalories per day, and then randomly assigned to pioglitazone 45 milligram or placebo for 18 months. And the primary outcome is at least 2 point in non-alcoholic fatty liver disease activity score in 2 histological categories without worsening of fibrosis. Secondary histological outcomes, hepatic triglyceride content measured by MRI and metabolic parameters. And the results you can see, steatosis reduction, everything statistically significant, inflammation, ballooning and fibrosis. So long-term pioglitazone treatment is safe and effective in patients with pre-diabetes or type 2 diabetes and NASH. These are 3 categories where it has been useful. Again, you can see the metabolic and hepatic characteristics after 18 months of pioglitazone. You can see here liver fat reduction, fasting and postprandial, HbA1c and free fatty acids, and liver fat content, everything was statistically significant with triglyceride reduction, HDL improvement is also seen in the parameters. Same thing in the graphical representation, you can see liver triglycerides, hepatic insulin sensitivity also increases, muscle insulin sensitivity also increases, adipose tissue insulin sensitivity again increases with the pioglitazone. Plasma AST enzymes, plasma ALT all decreased, HOMA-IR score improved, and adipose tissue insulin resistance also improved. So the conclusion is 3 years of pioglitazone treatment associated with long-term metabolic and histological improvement in patients with pre-diabetes or type 2 diabetes and NASH. Research suggests that NASH progression may be halted and natural history of disease can be modified with the use of pioglitazone in these patients. And again, this is effect of pioglitazone on NAFLD in type 2 diabetic patient using NAFLD fibrosis score. It's an Indian study. You can see the mean body index, nothing much of change, but you can see mean HbA1c are significantly decreased with pioglitazone. This is before treatment and after treatment, and again statistical significance is also there. Same thing, AST and ALT significantly decreased with pioglitazone. NAFLD fibrosis score significantly decreased after treatment with pioglitazone. You can see the fibrosis score again from 0.5 to 1.6. So 6 months treatment of pioglitazone significantly decreased your HbA1c, liver enzymes, and NAFLD fibrosis score. And again, one more thing, effect of pioglitazone on lipid profile and liver enzymes in type 2 diabetes we saw. You can see here, HbA1c before intervention, after intervention, statistically significant. Triglycerides and again improved. AST, ALT, and alkaline phosphatase, and weight also not no much of significance. So add-on pioglitazone is a good anti-diabetic agent in patients with type 2 diabetes who do not respond properly to maximum dose of glibenclamide and metformin. It improves liver function. That means these patients have absolute insulin resistance. And this one more trial, original article from New England Journal of Medicine, a placebo-controlled trial of pioglitazone in subjects with non-alcoholic steatohepatitis. 55 patients with IGT or type 2 diabetes and liver biopsy confirmed NASH. 6 months of treatment with hypocaloric diet, again same thing. Plus pioglitazone 45 mg or hypocaloric diet plus placebo. Evaluated for hepatic histological features and hepatic fat content by magnetic resonance spectroscopy. And again you can see the liver enzymes, inflammation reduced, plasma AST, hepatic fat content by MRI measurement, that also showed good improvement. Plasma adiponectin increased, steatosis and fibrosis reduction is also very much obvious. So pioglitazone led metabolic and histological improvement in NASH. Diet plus pioglitazone improved glycemic control, your liver normalized liver amino transferase, decreased plasma AST, and decreased ALT by 58% versus 34% in placebo, which was statistical significance. Hepatic fat content by 54%, and increased hepatic insulin sensitivity by 48%. Improved histological findings like steatosis, ballooning necrosis, and inflammation. And again, they are also statistically near normal. And greater reduction in necroinflammation, 85% versus 38%. Again, statistical significance is there. And again, this is a systematic review with network meta-analysis, comparative efficacy of pharmacologic therapies for fibrosis improvement and resolution of NASH. You can see the efficacy of pharmacologic therapies for fibrosis improvement and resolution of NASH. Meta-analysis of 26 trials with 5,000 and odd patients and 23 interventions. Follow-up duration was 24 to 104 weeks. Primary outcome more than or equal to 1 stage improvement in fibrosis. Secondary is NASH resolution. And you can see odds of achieving at least 1 stage improvement of fibrosis. Primary outcome was, these odds were statistically significantly higher in patients receiving obeticholic acid, pioglitazone, and vitamin E. And secondary outcomes, semaglutide, liraglutide odd was superior to placebo, vitamin E plus pioglitazone, and pioglitazone was superior versus the placebo. And lanifibranor, again one more molecule, was superior to placebo in resolution of NASH. The same thing in the forest plot picture. So ADA standards of care in 2024 recommendation. Pioglitazone or GLP receptor agonists are the preferred agents for the treatment of hyperglycemia in adults with type 2 diabetes with biopsy-proven NASH or those at high risk with clinically significant liver fibrosis using non-invasive test. Recommendation A. Early diagnosis and treatment of NAFLD offers the best opportunity for cirrhosis prevention. Pioglitazone and some GLP receptor 1 agonists are shown to be effective to treat steatohepatitis and may show slow fibrosis progression and decrease cardiovascular disease, which is the #1 cause of death in people with type 2 diabetes and NAFLD. Again, pioglitazone improves glucose and lipid metabolism and reverses steatohepatitis in people with pre-diabetes or type 2 diabetes and even without diabetes. So fibrosis also improved in some trials. A meta-analysis concluded that pioglitazone treatment results in resolution of NASH and may improve fibrosis. So pioglitazone may halt the accelerated pace of fibrosis progression observed in people with type 2 diabetes and is overall cost effective for the treatment of NASH. So lastly, take-home message is global diabetes crisis. We all know the numbers are increasing and nearly the global prevalence of metabolic associated liver disease is very high, more than 55.5%. And pioglitazone role in insulin sensitivity is a potent insulin sensitizer that improves insulin sensitivity in skeletal and cardiac muscle, liver, and adipose tissue. It is particularly beneficial for patients with insulin resistance, especially with those with renal impairment or cost concerns. Cardiovascular benefits, so many meta-analyses have been done and with clinical trials shown that pioglitazone significantly reduces the risk of major adverse cardiovascular events, including non-fatal myocardial infarction, stroke, and cardiovascular death, making it a valuable therapeutic option for high-risk patients. Efficacy in NAFLD and NASH management, pioglitazone are proven to be effective in treating non-alcoholic fatty liver disease, that is MAFLD, and non-alcoholic steatohepatitis, again MASH, particularly in patients with type 2 diabetes. It improves liver enzymes, reduces hepatic triglyceride content, and provides long-term histological and metabolic benefits. Guideline recommendation, leading diabetes and liver disease guidelines, including ADA 2024 standards, recommend pioglitazone or GLP-1 receptor agonist for managing hyperglycemia in patients with type 2 diabetes and NASH or significant liver fibrosis, underlining its importance in comprehensive diabetes care. Thank you.
Thank you, sir. It was one of the excellent, sir. Actually, very much thank you for taking this talk, sir, because my chief in GH always used to say, pioglitazone are very much underused molecule. So just one query from my side, sir. What about this newer molecule in lobeglitazone, sir? In pioglitazone and lobeglitazone, real world data, sir.
The claim is, they claim urinary bladder incidence is not there. That is the only thing as for now, because we don't have much of experience also. Only that is being claimed.
So now I take privilege to introduce Balamurugan sir, who is a chief diabetologist in the COVID Diabetic Specialty Center and chairman of IMA and AMS Wing Coimbatore. And sir is a life member of RSSDA and life member of API. It takes a very pleasure to introduce you, sir. Pleasure is mine, sir. Thank you, sir.
Yeah, thank you very much for the nice introduction, and good evening, everyone, dear friends. At the outset, I would like to thank the Scientific Committee and the Organizing Committee of this track 2024 for this opportunity to be with you today. After NAFLD, we are also going to talk about a topic which is closely related to NAFLD. How it is related, probably we will discuss at the end of the session and the question answers. So we will talk about reversal of diabetes, how, when, and for whom, and what are the practical implications on it. And is it a reversal, is it a remission or cure? Because a lot of different terms have been used. I just wanted to bring it to your knowledge that the important difference between remission and reversal. Reversal means a permanent cure. If you are reversing a disease, it's a permanent cure. On the other hand, remission is a temporary phenomena. And if you do not follow the other things after the remission period, it might come back again. That is why the reversal has not been accepted as a terminology, and we use remission now. And there is no cure as such. She said there is no cure for diabetes, and we don't use that. And this is one of the such example being the honeymoon phase of type 1 diabetes, where the patient undergoes a remission, where there's some residual insulin secretion, they're able to manage their life. So this is one of the examples for the remission. And what are the other remissions in diabetes? Type 2 diabetes per se, a remission following bariatric surgery, remission following reversing of a glucotoxicity. When there is a glucotoxicity, you are able to reverse. And then remission from stress hyperglycemia and increased blood glucose following infection. This is also one of the stage of which is possible remission. And again, this is data with diabetes remission after bariatric surgery. Various trials have been done with type 2 diabetes with a higher BMI, and almost, these people, almost 6-7 studies have been published in which they try to different procedures and try to reduce the weight, body weight loss. If you look at the weight loss, is ranging from around 5 kilos to almost 33 kilos in different studies. Almost they try to achieve an endpoint of A1C of around less than 5.7 to 6.5 in different studies, and there's been definitely improvement or the remission from the disease. It means the bariatric surgery in a selected population, mind you, it's a selected population, gives you a stage of diabetes remission. And what happens after the bariatric surgery? How do we remit? So there is altered gut physiology. Whenever there is a there is a decreased calorie intake following the bariatric surgery, increased jejunal nutrient sensing, increased intestinal gluconeogenesis. Again, the metabolic consequences being increased hepatic insulin sensitivity, on the other hand, reduction in the hepatic glucose production. And in the pancreas, it can cause the postprandial GLP-1 secretion and improving the beta cell function. And at the level of the muscle, there is increased glucose utilization, and there is an altered gut microbiota also following the bariatric surgery that all can improve the peripheral insulin sensitivity. One at the liver, then pancreas, then the peripheral insulin sensitivity. Then reduction in the anti-incretin factors, increase in GLP-1, PYY. So what all happens, there is a reduction in the body weight, there is a reduction in the anti-incretin factor. All these are possible mechanisms by which remission occurs following a bariatric surgery. This again, when it's a glucotoxicity, when you are able to reverse the glucotoxicity by different mechanism. So whenever newly detected diabetic patient comes, we always tell them the first 5 years of diabetes is called as the golden period of diabetes. If you are able to motivate them and get them into good control of diabetes, even after a few years, if the diabetes was not under control, they are free from complication. This was the lesson we learned from the UKPDS follow-up data, and we call this as the glycemic memory or the legacy effect. So that's why sometimes patients also read, "Doctor, my sugar is less, why are you starting on insulin?" People want more time to start on insulin. So early insulin therapy can reverse glucotoxicity and give your beta cells a rest and the definite scope of remission in them. And these are various studies done with the reversal of glucotoxicity by various authors in the newly diagnosed type 2 diabetic patients. They try to use a continuous subcutaneous insulin infusions. On the other hand, they try to use a multiple daily injections of insulin. Almost the study ranges from 2 weeks to 12 weeks, and almost, the follow-up that did for 6 months to 2 years, and there was a good, they tried to fix a fasting plasma glucose less than 7 and PPG less than 10. And some studies focused on a A1C of 7%. Most of them had a good rates of remission. So the result being, the moral of the story being, whatever mechanism, you bring down the blood sugar and you bring down your body weight, you are going to remit from diabetes. There's definite scope. So the glucotoxicity has to be reversed, and many a time we find patients coming to us with HbA1c of 9, 10 and 11, and the patients has not been given a benefit of insulin. And this is a report from the, I think, Barbados study. I read a high 19% prevalence of diabetes among adults, and 1 in 3 adults were obese. And this Barbados study also had a designed to test the feasibility of 8-week low-caloric diet, and they were followed up for 6 months. And these people within the Barbados also, they are definite weight reduction and they've been free from remission. And this is just a liver, looking at the normal liver, on the other hand, liver with type 2 diabetes. You can see the insulin content and as well as the fat content. The liver fat percentage is high in people with type 2 diabetes in contrast to the normal. This is what previously we have been talking. So whatever mechanism, if you are able to reduce the liver fat, so you are addressing the insulin resistance at the stage of liver. And this is helpful. And again, this reversal, this is the study called counterpoint study, by which whenever normalize the beta cell function, by reducing the blood glucose, there is a definite evidence that the beta cell function also is improved. And this is again the data of the insulin, sugars, A1C, following, and again look at the pancreatic triglyceride content, as well as the first phase of insulin secretion. You can see once you are able to reverse it or normalize that, the beta cell function, the first phase of insulin secretion increases, and again the pancreatic triglyceride content also comes down. This is called one of the landmark trials in remission. It's called DIRECT trial. This was deduced from a study conducted between July 25th, 2014 and August 2017 among 298 people aged 20 to 65 and diagnosed with the disease in the past 6 years. And there was the 3 steps program, okay. And step 1, low calorie formula diet, approximately 850 calories daily for 3 to 5 months. And the second step, stepped up food introduction 2 to 8 weeks. Then later, step 3, ongoing support for weight loss maintenance with strategies to increase the physical activity. What is the result? a year later, we found that 46% of the participants who lost weight significantly did not have diabetes. The highest was those who lost more than 15 kilos. Why we are talking on the weight? Because any weight reduction mechanism, whether diet or exercise or drugs or surgery, is going to help in reversing or remitting diabetes. This is again a direct study. Primary care-led weight management for remission program also had a similar results. Almost, the similar results, almost intensive lifestyle intervention, body weight, and this is again called Diadem 1 study. It's an open label, parallel group, randomized control trial. Here also we found the patients in the intensive arm, they had a reduction in the sugars and HbA1c and body weight. And what are the major studies investigating? We talked about the direct study, Diadem study, and the Veta Health study. All the studies, they try to have the maximum the meal replacement followed by a gradual introduction of the food. This was followed in first two studies, and there was a ketogenic diet in the Veta Health study. Almost all the studies, they had definite some roles of remission following the weight reduction, following the dietary intervention. They try to look at the low calorie diet versus low carb diet, and the upper two are the sleeve gastrectomy and gastric bypass. Here also you can see then there's the surgical side, there's a drastic reduction very fast compared to that, but the other two mechanisms also gradually weight reduction. On the other hand, after some time, slowly the blood sugar and A1C increases. This is what you must know, that the graph slowly after 2 years slowly increases, because most of the time people are not able to control the diet, and the remission rates of type 2 diabetes is very low calorie diet. This is what newly diagnosed type 2 diabetes, they try to give a very low calorie diet. I said different studies are there, almost ranging from 2 months to 11 months, and almost the remission rates were around 46 to 100% in different studies. And who is Dr. Roy Taylor, the Magnetic Resonance Center Institute, what did he say? And the twin cycle hypothesis, diabetes and reversal. Okay, when we have a liver cycle, on the other hand, the pancreatic cycle. This is also being discussed in MASLD. And see, whenever there is a positive calorie balance, there is increased liver fat, the liver cycle, there is resistance to insulin, suppression of the glucose production. On the other hand, whenever there is VLDL triglyceride increase islet triglyceride, there is insulin reduction in the insulin response to ingested glucose, which acts on the pancreatic cycle, which causes the postprandial glucose. So whenever there is a basal insulin defect, it's going to be a fasting sugar elevation. Whenever there is a postprandial glucose elevation because of the decreased insulin response at the pancreatic level, can cause the diabetes. So when you are able to reverse these things, okay, whenever you are able to reduce the liver fat export, pancreatic fat, and reduction in the beta cell function. So remission, what happens? Reduction in the liver fat, reduction in the VLDL, liver fat export reduction, the pancreatic fat reduction, and improvement in the beta cell function. I think it's very simple to understand. This is the twin cycle hypothesis. See, whatever the balances you can do, the hand by the calorie excess and insulin resistance, and you see it is mainly by the VL triglyceride. See, so reduction so when you're able to modify your lifestyle in terms of diet, modified diet programs, as well as the improved utilization by energy, by definitely by your physical activity, you can improve your reduce the liver fat content and increase your basal insulin secretion. Again, improve the insulin resistance, and there can be improvement in the acute insulin response to food. This is what Taylor's twin cycle theory. When you are able to modify that positively, there is a reduction in the glucose. If you're not doing, on the other hand, there is a increase in the sugar and uncontrolled diabetes. This is again remission regarding the weight loss. This study was published by Tom Meso 2020 in Diabetic Medicine. Here also you can see, whenever people who lost more weight, we can see 5 kilos, 5 to 10, and 10 to 15 kilos. And whenever who lost more weight loss and reduction to more remission rates in diabetes. And this is again, people with normal diabetes or BMI also, when you are able to put the calorie restriction and weight reduction, and they are able to achieve the remission. This is called Retune study. And so what are the predictors of reversal or remission? As already time and again I tell you, the weight loss there's the strongest evidence. What are the favorable markers? Who all patients, who are favored candidates who can go on for remission? One, fewer anti-diabetes medication, and second, not on insulin therapy, lower baseline A1C, and old age and male sex. They are all favorable markers for people who can go for a remission. What are the independent markers? The basal BMI, fasting insulin, fasting C-peptide, and diabetes duration. And you friends, whenever the longer duration of the diabetes, it is very, very difficult to use the term as remission, where it's practically impossible. So what are the non-favorable markers? Anxiety, depression, high triglyceride and high GGT. And what are the various strategies? You look into the different body mass index. Whenever the body mass index is very high, we use strategies called the bariatric surgery and metformin-based combination. Then other next category of BMI, we can use a GLP-1 receptor agonist and SGLT2. Again, we can use that insulin plus metformin-based regimens. Whenever the BMI is low, we can use a short intensive insulin therapy. This is what we discussed, when reversing the glucotoxicity. So by giving insulin. So when the BMI is more, they respond to treatment like GLP-1 receptor, metformin, and bariatric surgery. And so these are the way. When you are able to reduce the weight, you can reduce the progression, and you can cut what is called as regression to normal glucose intolerance. And if the weight is going to increase, they can move on to the right side, the red, the progression of type 2 diabetes. So calorie-based restriction-based weight reduction definitely helpful. And this is called precision nutrition program. The different stages. Stage 0, whenever there's more than 1 year, no medication and A1C of 5.7. Stage 2, no medication but A1C 5.7. Stage 2, again no medication, A1C 5.7 to 6.4. Another stage 3 is again estimated A1C of less than 6.5, and fourth is metformin, and fifth 2 oral medications, stage 6 at least 3 anti-diabetic medication. What we want to tell you is, whatever the nutrition come, whenever you have more medications, patients are longer the duration of diabetes, when the patient is taking more drugs, definitely the percentage of remission is going to be less, whatever method you follow in the intervention. This is what we have learned from the precision nutrition program. And again, what are the consensus reported definition and interpretation of remission of type 2 diabetes? What is the optimal terminology to be used? The resolution, reversal, remission and cure. This is accepted terminology is remission. Glycemic category, HbA1c less than 6.5 for at least 3 months without medication. Continuous glucose monitoring devices, we can use the estimated A1C less than 6 point can also be considered. Diabetes relapse. So weight gain, stress from other forms of illness and continuing decline in the beta cell function can all lead to the recurrence of diabetes. That is why we carefully use the term called remission. What about the complications after remission in diabetes? Even after remission, the classic complications of diabetes, including retinopathy, nephropathy, neuropathy, and enhanced risk of cardiovascular disease can still occur. And the long-term outcomes of remission are mortality, cardiovascular events, functional capacity, and quality of life are unknown till now. So we need to wait for some more data. So summary, the reversal of diabetes, we sometimes people call, but remission, but the conditions apply. When you read a long document, finally they put a small thing like conditions apply. If you do not see the conditions and tell everyone, then you will be at trouble. So thank you, my dear friends. Nothing impermanent in life. Diabetes is not an exception. So we can all try to because today you can see the lot of apps in the social media, and a lot of people are marketing the reversal program. A lot of non-medical people are promoting. You charge 50,000 to 1 lakh rupees, put them in a continuous glucose monitoring system and diet. They're giving nutritional supplements, nutritional replacement. I think the concept, all our colleagues who come here can promote this concept in scientifically. If we promote that, definitely, now people are asking everywhere, whenever I go for the Rotary meeting or a public meeting, there's always the question about, sir, doctor, about diabetes reversal. And there's another interesting topic is intermittent fasting. All people know, not non-doctors, I'm telling you. So definitely we can start practicing this concept, and definitely you can be financially also more soundful. Okay? If you are going to put a separate group of people and put them, it may help you not only scientifically, also, one, the doctor has cured me of diabetes. You know, that itself is a big marketing formula, USP for you. Second one, financially also you can charge. So these are all scientific evidence, friends. Thank you very much for the opportunity.
Thank you, sir. Thank you for your elaborate explanation. Thank you. Next speaker, I call upon Dr. V. Ravindranath. He is a chairman and managing director, Prabhu Diabetic Multispecialty Center, Trichy. He is a principal co-investigator, more than 30 international journals, and published article and peer-reviewed journals. Over to Dr. Ravindranath. He is talk about important topic, ED in diabetes, treatment and management.
So thank you, sir. Thank you for the nice introduction. Sir, time இனிமேல் வரும் சார் ரொம்ப நாள் லேட் ஆயிடுச்சு 15 minutes ரொம்ப very short time to deal this topic. Within 15 minutes time, no, we're not able to cover up the entire scenario of somehow we'll make it up and no conflicts of interest and definitely you can take photographs and videograph but don't accept anything. Okay, very simple topic only. So definition, sexual dysfunction refers to a problem during any phase of the sexual response cycle that prevents the individual of couple from experiencing the satisfaction from the sexual activity. And the sexual response cycle includes the excitement, plateau, orgasm, and resolution, and I'm not going to detail about it. The concise Oxford Dictionary defines impotence as powerless, helpless, decrepit, wholly lacking in the sexual powers. The new terms, erectile dysfunction is apt, and then it is maintains the self-esteem and the quality of life. So there are many problems. The common problems are the reduced libido, inhibited sexual desire, and erectile dysfunction. And the third thing is ejaculatory failure with a retarded, absent, or premature or retrograde. I'm going to deal only with the erectile dysfunction management. So erectile dysfunction defines as an inability of the male to attain and maintain the erection of penis sufficient to permit a satisfactory sexual intercourse or penetration. So coming to the, I'm just plunging into the management only because I'm not going to the pathophysiology and too many details, clinical features and all. So the main important things that we want to do in assessing the patient with erectile management, dysfunction and the management, the art of history taking is very important. This is carry more value to say whether the patient has got a decreased libido or erectile dysfunction or ejaculatory failure, because commonly all put together the patient say, sir, I am not able to perform sex, they say that I am impotent. So you have to discover the problem. So careful and tactful elucidation is needed, vagueness must be clarified, choice of terminology should be used very precautionally, and all the questions should be open also. And certain times you have to keep silence and repetition can be done. Social history, medical history, all the other parameters are mandatory to take from the patients. And of course, are there problems in the relationship should be asked? What are the stress factors as seen by the patient and by the partners? What type of sexual problem they encounter in detail, in their own verbal, in their own language they should tell. And is there any anxiety, guilt or anger expressed? And are there any physical problems such as pain or other things felt by the partners? Treatment, general conditions show improvement, diabetes control, BP control, cholesterol control, as usual. Nausea, vomiting, diarrhea, for any side effects, you have to control all the parameters and then only you have to go for the therapy. Psychosexual therapy, medical and surgical treatments are the option. So, medical management, coming to the medical management, you know pretty well all the fills are available, sildenafil, vardenafil, tadalafil, avanafil, udinafil and the mirodenafil. So, it is named as a fill only. Probably it fills the cavernous spaces. So that's why they named fill, I do not know, but all the fills are there. Only the sildenafil and vardenafil is now, tadalafil is available in India, other things are not available here. So managing the erectile dysfunction is the first line treatment is prescribing the PDE5 inhibitors. However, whatever you prescribe the patient, whether any molecules, sildenafil or vardenafil or tadalafil, 30 to 35% of the ED patients do not respond to the drug because of various factors. One is the inadequate dosages, administration of a single dose, and a lack of dose regulation. And these are the main categories that you can encounter why we fail to achieve the proper erection when even if we prescribe a PDE5 inhibitors. They are called the non-responders due to various factors, which I can go one by one. The possible causes for the ED in PDE5 inhibitors, non-responders, how it causes. You know pretty well, the molecule PDE5 inhibitors has got a beautiful action on the cyclic GMP and the cyclic AMP, where it enhances the nitric oxide release and thereby relaxation of the smooth muscles and the increased blood flow and the penile erection. We call it as a tumescence. Tumescence is the penile erection, we call it. So it is achieved. But in fact, you can see this decreases as the age advances. Why this age advances? No, not aging factor alone is not only important, but also other comorbid conditions that exist: diabetes, cardiovascular disease, metabolic syndrome, late onset hypogonadism, and hypertension, obesity. All these factors play a major role, where you can see the penile musculature is deranged. The penile musculature goes for a dysfunction. Even the vascular structure deranged, nervous system, neuroendocrine system, all the systems are affected as the age advances, and also with the comorbid condition, all these things derangements occurs. That is why when you prescribe the PDE5 inhibitor, certain patients will not get any response at all. If you prescribe a Viagra tablet 50 mg, 100 mg, they don't get proper action. Probably 1 or 2 times they get. After a month they will come, sir, previously it was acting, sir, but now it is not acting, sir. I'm not able to get it. Even 50 and 100 also, we're not able to. So there are so many factors we will see one by one. So the comorbid conditions, diabetes and sex hormones, the lower testosterone levels also contribute. So the late onset hypogonadism is one of the main factor. And medication side effects, iatrogenic factors like SSRI drugs or the thiazide beta blockers, and unhealthy lifestyle behavior, all this contributes to the non-responsiveness of the drugs. Of course, the complications of the treatment, impact on the treatment efficacy also. Patient undergone these kind of surgeries, radical prostatectomy or pelvic radiation therapy, spinal cord injury or trauma-related picture, all these things definitely will hinder the action of the PDE5 inhibitors. Of course, how to overcome these PDE5 non-responders? So administration factors you can see, optimizing the treatment efficacy. There are some incorrect administration factors that we encounter. Taking the medications after the heavy meals, lack of sexual stimulation, and incorrect administration timely, and too few attempts to achieve the erections, and other unidentified factors. All these things are the incorrect administration factors, and the consequences of the above all these things that has got a reduced efficacy of the drug efficacy, decreased patient satisfaction, and potential discontinuation of the treatment. Of course, how to optimize the PDE5 inhibitors administration. Correcting the administration time also is important. Choosing the right drug regimen, choosing the right PDE5 inhibitors regimen is important. Considering the metabolic and distribution characteristics and ensuring the adequate sexual stimulation. Of course, the PDE5 inhibitors regimen adjustments we can see, switching to a different type of PDE5 inhibitors drug. When you prescribe tadalafil, you can switch over to sildenafil. If you want, you have the patient already on sildenafil, you can switch over to tadalafil. So switching to a different PDE5 is one of the things that we can follow. Adjusting the dosage and frequency is most important, and monitoring the patient's response and adjusting the regimen also is more important. So sufficient medication attempt, insufficient medication attempts should be focused on longer duration and continue treatment beyond the initial doses. 80% of the patients with sildenafil achieved successful intercourse within 8 attempts at 10 mg and 4 attempts at 20 mg. So need an adequate PDE5 inhibitors blood levels also. Increased PDA doses also is necessary. Once you start the therapy, you have to go on intense with the therapy. 50 mg of sildenafil should be increased to 100 mg, and appropriately all the other PDE5 inhibitors doses should be go to the maximum level. And of course, starting from the highest dose is one of the main things that we can avoid the non-responders. Start with the highest therapeutic dose, and then you can step down the dose as the days goes on. The increased dose may be an important strategy in PDE5 inhibitors non-responders. And even the different dosing regimens is also important. 2 dosing on-demand daily and previously unresponsive to on-demand daily flexible tadalafil significantly improved. The sexual encounter probably is much improved in this faculty, and so the tadalafil daily dosing regimen, every day you can go on giving the dosage for a longer duration of time in previously and on-demand tadalafil non-responders. Of course, even a different, as I told you, different drugs can be used. PDE5 inhibitors can be chosen. Need for 5 mg every day is also nowadays also, so many studies have come. Every day the patient can take 5 mg of tadalafil for their lifetime, and then and there, if you want a boost up dose, you can give the extra dose when they go to perform a sexual activity. And even the combined use of long-acting, short-acting PDE5 inhibitors also is there. Once the low dose of PDE5 long-acting inhibitors, it has got a tendency to repair the injury to penile vasculature endothelium, and it rectifies the muscular derangements and dysfunction and improves the function. So even you can combine long-acting and with the short-acting PDE5 inhibitors. So you can even combine L-arginine, which will enhance the potency of the drug. And of course, contraindication for these inhibitors are significant cardiac events, PDR, retinitis pigmentosa, and patients on the NaION. apomorphine, yohimbine, trazodone, other drugs. Alprastatil injection, intracavernous injection also is possible, but only thing priapism is more common side effects. The antidote for the priapism is the pseudoephedrine injection. Of course, intraurethral suppositories are there, Muse, and even vascular constriction devices also there, and vacuum pumps are there. Surgical treatment also has got a semi-rigid rod implantation, mechanical rod implantation, malleable devices all available. Of course, the anti-diabetic drugs, metformin, improve the endothelial dysfunction, dependent vasodilatation and insulin resistance also. It improves the testosterone levels and should be considered in patients with ED. Pioglitazone has got an activation in the PPR gamma, thereby the endothelial dysfunction, oxidative stress, metabolic disorders, everything is get corrected, and reduction in the high cholesterol level also. So ED patients can be easily prescribed metformin and pioglitazone. But this clavin should be avoided because it is blocking the agent of KATP channels and significantly reduce the relaxation of the arterial muscles of the penis also, so should be avoided. Other sulfonylurea, we are not able to get any informations. SGLT inhibitors also significantly improve the erectile dysfunction. DPP1 inhibitors, GLP-1 receptor agonists are also very much favorable of improvement in the sexual dysfunction. Of course, in insulin also. Insulin is the drug of choice for any kind of disease, and even the sexual dysfunction may restore the erectile dysfunction. You know, other premature ejaculations and retarded, I'm not going to deal this subject in depth. So the take-home message, despite the fact that men with diabetes now have a host of options for addressing ED, so many drugs have come to the market and so many method of dosage administration is mandatory. Even you can proceed 2 PDAs also at the single patients, one long-acting and one short-acting. Combined therapy is also possible. And preventive education concerning the risk factors that lead to this disorder should be incorporated into diabetes management programs. So try to detect ED as early as possible with all means. And it is an indicator of the endothelial dysfunction. Of course, you can assess the cardiovascular risk factors. So, concluding remarks, sexual act is an art. So, train the patient who are ignorant of it. Train the patient means you have to educate the patient in the proper way. And sexual dysfunction is a part of one of the complications of the diabetes and a marker of CVD. And if you make yourself thorough in diagnosing and treating sexual dysfunction in time, we can avoid all the cardiovascular events and even many divorces. So, delay in justice is an injustice. Thank you.
Thank you, sir. Thank you for nice presentation. One question. Any question from the floor?
This is a point I like to share. So what is there in type reversal? Reversal of diabetes is common with the type 2 diabetes. That is, remission is common with type 2 diabetes. Reversal in type 1 diabetes. Reversal, you are bringing up the beta cells, number of cells. So when beta cells are increased, you can reverse it. Whereas here, beta cell dysfunction is there. You are decreasing insulin resistance by all the methods, diet, exercise, all these things. Thereby, insulin resistance is improved. It is what become a remission. When beta cells increase in numbers, it becomes a reversal. The reversal can occur with the type 1 diabetes because of CD3 antibodies, CD4 antibodies are very useful in bringing down the beta cell failure or beta destruction. So that two terms you can use it, sir, interchangeably.
I just want to refer that even in patients with type 2 diabetes, I have presented some data in which they looked at the beta cell functions also. The calorie restrictions and all have showed improvement in the beta cell function also. Probably we'll see. Yeah.
Any patient aged more than 55 to 60, probably you have to assess the testosterone level for any erectile dysfunction. But only thing, after careful elucidation of the art of the history taking from the patient, see whether the patient has got a decreased libido. That is more important. And second thing only, erectile dysfunction, then only ejaculatory failures. So all the 3 histories should be properly elucidated. When the patient comes and says, sir, I'm not having even the sexual feeling at all, that means lack of libido. That is the only late onset of hypogonadism. So at that time, the patient definitely needs testosterone. Not for all the patients you can do testosterone level. Initially, you can manage with other things. So probably age after 50, 55 years, 60 years, with the symptoms of hypogonadism, probably if you palpation, I will not mention here. For clinical examination, we had to examine the scrotum. You got to assess the testicles. So you see for the testicle size And if it is smaller and spongy, probably you have to go for think of a hypogonadism and test the testosterone level, number one. And if you want to test the testosterone, both the things should be assessed, free and total you have to assess. So the main thing is we have to ask whether the libido is there or not. Libido is there, sir. I'm having the sexual feelings there, but I'm not getting erected. That is erectile dysfunction. Sir, I'm getting the feelings there. Libido is there. I'm getting erection, but I'm not able to ejaculate. That is ejaculatory failure. So all the three histories should be elicited properly.
Yes, sir. Very nice point, sir. Actually, in young, but now in practice, probably everyone would have experienced young adults, that is around age 35, 25 to 35, they are coming with the erectile dysfunction. I don't think it's all due to the organic. It's a psychological. So more than in the young group, more than 90% psychological. Probably once diabetic or other comorbids, we can think of the organic problem. So for them, the use of SSRI, small dose, just to bring down the anxiety level, depression level, probably it improves the sex. So that's what we've been practicing.
Yes.
So I just a point.
Most of the ED are mostly functional only.
Yes.
Functional. Most of the.
Sir, alcohol will create an interest, but it will rob the pleasure of it.
Alcohol in moderation is good, sir, but alcohol, when it goes excess, definitely here.
Sir, who is listening to moderate and medium?
It's as to the
Sir,
textbooks, sir.
once they take the cup,
Yes,
that is the
they
end
go
of the
off.
story. And one more thing, sir. I have used tadalafil extensively on a long-term basis, 5 milligrams per day. It gives fantastic result.
Tadalafil.
Tadalafil. Sir.
Tadalafil,
Yes,
yeah.
yes,
There are so many European studies have come where they used tadalafil for a lifelong time. Every day they used to take 5 mg, and whenever they want an extra sex, you can take the other sildenafil an extra dose.
So
also.
you want to combine sildenafil along with tadalafil, sildenafil 50 and tadalafil 5 for extra.
Extra.
Am I correct, sir?
Combined, yes, combined pill.
So whether this yohimbine alkaloids,
Yohimbine has got all the
is it
side effects.
available, sir?
Not available, sir, not available. Yohimbine and other things are not available, and it produces a lot of side effects. Previously, those ancient days, they were trying all these drugs. Just as completion's sake, I narrated here.
You are not touched upon premature ejaculation, am I correct?
Pardon, sir?
Premature ejaculation you have not touched
So
upon.
this topic only for
Yeah,
dysfunction,
just
sir.
one, just-
There are premature, retrograde ejaculation is there, premature. We are not dealing all these things, sir. They given me management of erectile dysfunction only. That's why I didn't go for. So that's an elaborate topic.
Yes, sir.
Because
Regarding pioglitazone, what is the dose which you expect to be given to the patient, sir? Because in Western population, they go up to 45, which is not acceptable to Southeast Asian population. Here, even 30 we don't give, sir. Now we give only 7.5. I think so that is the safest level of giving to the patient. And do you think this 7.5 is going to have any effect on MACLD, sir?
Yeah, in nearly 60% of the patient, we use 7.5, and 15 in nearly 30 to 40% of the patient, and 2 to 5% only I go above 30. That is very, very less. But NAFLD, the dose is 45 milligram. As said, it is not 7.5. We don't have any studies.
That's what I asked
That's the
you,
thing.
sir.
We don't know.
But I think so Saraglitazone has got some role to play,
Yeah,
sir.
that has both alpha and gamma.
In fact, I have been a part of a phase 3 clinical trial with the dual agonists, the saroglitazar, both alpha and gamma agonists. It was a liver biopsy-driven trial, phase 3 trial. Shows definitely an improvement,
Really?
especially lowering the fatty liver content, apoptosis, and to a small extent fibrosis. I think it's been approved by the DCGA,
Yeah,
Drug Controller
DCGA.
General, as a, because
Yes.
in Indian context, you should talk about the Indian data also, no? You know, Selvavandian.
It's a
Because
because it
you
was-
talked about FDA now, ADA, and Drug Controller General of India has
Saroglitazar, yeah.
approved the saroglitazar for the
Because it was-
usage of the NAFLD. As already I said in my topic, we both are closely related topics. So whatever mechanisms by which you are able to reduce 5 to 10% of your body weight, definitely you are reducing or reversing the liver fat content and NAFLD also.
Improve the insulin sensitivity.
Yeah.
The only thing with saroglitazole is that, sir, the cardiac trials of Indian studies, we are little.
No, cardiac data, because this is mainly we are looking at the, NAFLD per se, not only because it is not basically, now they are on a trial with they registered a trial with the US FDA, it is under on. So anytime the results are also expected. And so far, the only evidence is there is another drug which is coming up, thyroid receptor agonist. I think what is the name?
Sobi.
Resperatron, which is coming up, thyroid receptor antagonist. No, sir. Sir, please, sir. No, it's a scientific forum. It is coming new. Yeah, available in USA. It's going to come to India, sir. Probably, Rangarajan, sir, you can use for selected patients. I just want to know the drugs which are approved for that indication. Because off-label using of drugs is totally different. And what is approved by the regulatory authority is very, very important. And we are not supposed to talk about anything off-label in a scientific forum and meeting, as well as the, anyway, we are not supposed to talk on that, I think.
Points about this PD5, we all discuss about erectile dysfunction. All should know we are using it for primary pulmonary hypertension. But the dose is sildenafil, here only 20 milligram per day, but I don't know, tadalafil they give again 20 milligram per day for PPH, one. Second, if somebody is have a BPH, now the combination drugs are available with tamsulosin or alpha-susin plus PD5 as a regular dose, which is supposed to reduce the congestion of prostate. And contract the prostate. And regarding glitazone, as you said correctly, we are underusing it. Sir, as you said, 45 milligram is only for the good effect. But for diabetes, atherosclerosis, effect on the liver, effect on the gut, effect on the metabolism, maximum 50 milligram, the study is approved. 7.5 or 15. Except somebody have an obvious cardiac failure, they have a fluid overload, dyspnea and exertion, this can be continued even at little 50 years or so. We have been using, it's a very wonderful drug. Thank you.
Monitoring, it needs a continuous monitoring.
Because, Selvapanin, because the wonderful mechanism about the pioglitazone itself, because there's a unique drug, which acts on the nuclear transcription level and then mRNA. None of the diabetes drugs
No
are so
other
far
OHA,
addressed.
attacks
So
at
that
the
was
nuclear level.
definitely, many a time we get a patient with the pioglitazone, we stop that and it's very difficult to get the control back. Vetri, sir?
Dr. Silva, the theme of partial PPR gamma agonism can be utilized for achieving the same effect by reducing the dose of. There is a phenomenon known as PPR gamma partial agonism. For example, conventionally people are advocating 30, 15. Can we reduce it to half to achieve the same effects using this phenomenon?
We don't have evidence. That's the thing, sir.
PPR gamma partial agonism is a phenomenon which is useful for reducing the dosage to have the same effect.
Theoretically, it is proved or something, but we don't have any
Evidence.
guidelines or trials. We don't have any trials.
Can
Theoretically possible, yeah.
Probably what I want to conclude is
We
that
thank
the
the
evidence
speakers.
available so far, it is not very robust. Probably we need, Vetrivel sir, probably we need more robust data to categorically say this can be used for the clinical, can be translated into a clinical practice. We have to wait and watch.
We thank the speakers for the excellent speech.